Cardiovascular diseases mainly refer to diseases caused by an alteration of cerebral circulation, coronary circulation, or peripheral circulation. When the problem is in the carotid artery, the clinical consequence is represented by transient ischemic attacks of stroke. When the problem is in the coronary circulation, then the most impressive clinical consequence is myocardial infarction or sudden death. When the problem is in the peripheral circulation, then the clinical consequence are what we call claudication intermittens or critical limb ischemia, which is an extreme situation where the limb becomes at risk in a short way. Uh, the process leading to these different clinical manifestations is always the same and is represented by atherosclerosis, or we better say atherothrombosis, which is a progressive disease triggered by risk factors, which results in a chronic smoldering inflammation of the arterial wall. And then this slowly progressive disease, which affects the arterial wall, can eventually end up, because complicated by thrombus formation, in these more, let's say, clinically extreme manifestations of atherothrombosis, which are stroke, myocardial infarction, and critical limb ischemia. Regarding the prevalence, well, definitely cardiovascular disease are the killer number one. In Europe, about 40% of men die of cardiovascular diseases, and 50% of women, even more, die of cardiovascular disease. And both for men and women, cardiovascular mortality related to ischemic heart disease, in other words, the disease which affects coronary artery, leading to infarction, sudden death, heart failure, well, mortality related caused by ischemic heart disease is about 10%, both in men and in women. Yes, the first profound difference is that in men, the most prevalent manifestation of ischemic heart disease, now let's focus on ischemic heart disease, the most frequent presentation for men is characterized by obstructive atherosclerosis. In other words, flow limiting stenosis, which develop in the coronary circulation and eventually leading to angina or acute myocardial infarction. While in men, the most prevalent presentation is represented by coronary microvascular dysfunction. In the past few years, in the last 10 years mainly, we have been learning that the clinical presentations of ischemic heart disease are more complex than we thought many years ago, because there are two fundamental mechanisms which can lead to ischemic heart disease. One mechanism is represented by an anatomical alteration of epicardial arteries, leading to the formation of coronary stenosis, and this is more prevalent in men. But another presentation is represented by a functional alteration of coronary circulation, in particular of coronary microcirculation. In this case, we do not have stenosis, but we can have angina and ischemia caused by a functional alteration of coronary microcirculation. The second form, a functional alteration of coronary microcirculation, is more prevalent in women than in men. At the end of the day, the outcome is similar for men and women. As I as I said before, 20% of men and 20% of women die because of ischemic heart disease. Although the clinical presentations are different, but the outcomes are similar. Another major difference is that because of the what we call estrogen umbrella, the protection given by estrogen, the onset of disease in women is about, on average, 10 years later than in men. So the onset of disease is to some extent, takes place to some extent later in women than in men. But unfortunately, women then catch up very quickly. And at the end of the day, mortality is almost identical for men and women. A wonderful question. For several decades, we have been sitting comfortably on the risk factors identified in the Framingham study long ago. Long ago, the Framingham study showed that four called at that time risk factors, which are smoking, hypertension, dyslipidemias, and diabetes, uh, they found that these four risk factors were associated to higher risk of ischemic heart disease and cardiovascular disease in general. Then trials and Mendelian randomizations showed that these risk factors, these statistical epidemiological associations, were not just simply associations, but these four risk factors indeed are causative. They cause atherosclerosis and the clinical presentations of atherosclerosis. So epidemiology just shows association. Then trials in particular showed that these risk factors are causal in terms of atherosclerosis, regarding atherosclerosis. And this has been clarified mainly by trial. The first trial, the 4S trial, showing that the reduction of cholesterol reduces cardiovascular risk, is the evidence that LDL cholesterol in particular is a cause of atherothrombosis. So with the passage of time, these four risk factors and the last one, which has been added to the original four more recently, which is obesity, well, all these five risk factors are indeed cause of cardiovascular diseases. And we have been sitting comfortably on these five risk factors for many years. But a few months ago, I woke up reading a very interesting study published in the New England Journal of Medicine, showing that these traditional risk factors only explain in the five continents, in men and in women, only explain 50 to 60% of cardiovascular events. So there is a residual risk, which is, we tend to call it residual, but it's a bit more than residual. There is a 40 to 50% risk, which is not explained by traditional risk factors. So what is the message? The message is that we have to be extremely efficient in controlling the traditional risk factors. I repeat, smoking, hypertension, diabetes, dyslipidemias, and obesity. So we must be extremely rigorous in controlling these risk factors as early as possible, from childhood, ideally, in order to abate the risk of cardiovascular disease. But keeping in mind that these results, which is achievable because we know this causal factor of atherothrombosis, only explains, only reduces 50% of cardiovascular events. Well, this is the question, how to explain what is the cause of the remaining 50% of risk. And we are using more and more a term which is becoming popular, which is the exposome. The exposome represents the main reason of unexplained risk for ischemic heart disease. for cardiovascular disease, which again is 50% of the total risk. And the exposome is more than air pollution. Exposome is the sum of three different risk factors which are emerging. One is indeed pollution, but not just air pollution, but also acoustic and light pollution. Any excess in our environment, not only air pollution, but again, too much noise, too much light, they are risk factors for ischemic heart disease and for cardiovascular disease in general. And this is one component of the exposome. The second component is represented by infections. There is clear and growing evidence that infection, chronic or recurrent infections, are an important cause of cardiovascular disease. We have recent data showing that after, for instance, an acute exacerbation of obstructive pulmonary disease, chronic obstructive pulmonary disease, we know that these patients have recurrent exacerbations. Well, in the month after this acute pulmonary event, the risk of myocardial infarction is 10 times higher than in control subjects. And this is just one example. There's good evidence that poor oral hygiene, as simple as that, poor oral hygiene remarkably increases the risk of cardiovascular events. So what we are learning is that the global burden of infections is another important risk factor and causative, leading to cardiovascular events. Causative because infection, like air pollution, they trigger this chronic smoldering disease, inflammatory disease, which we call atherosclerosis. Coming back to the exposome, pollution, infections, the third element important for the exposome is the social status and the presence of psychological negative factors like loneliness, social isolation, depression, a low socioeconomic status. All these are risk factors, but probably more than just risk factors, again, causal factors to a large extent of ischemic heart disease. RNA-based treatment are really already changing our approach to prevention. And well, paradoxically, thanks to COVID, because this technology was already there. And the same technology is now fundamental also to control risk factors. Now, what are the advantages of these new technologies? Well, there are two main advantages. One is that they are really a sort of magic bullet which go precisely on the target. Well, this is an expression which was coined more than 100 years ago by a great German pharmacologist, Paul Ehrlich, who once wrote, well, what we need are magic bullets, drugs which go straight where they must go without causing any other effect. And now, after more than 100, really we have the magic bullet, because this RNA technology, in this case, allows to reduce levels of LDL cholesterol by targeting the production of a specific protein in the hepatocytes. So this RNA technology really allows us to have a magic bullet. So this is one first advantage. But the second major advantage is that the effect of this RNA technologies, RNA-based treatments, is that their duration of action is for months, not for hours or days. We're used to drugs which work for hours or days. These new drugs based on RNA, they work for not for a week, but they work for months. This means that we can, in a sense, vaccinate our patients against cholesterol, as noted some years ago by Professor Brownwell, with two injections, like a vaccine. And this is really remarkably new. To sum up, three main advantages with these new RNA-based technologies. The first is lack of predictable side effects. Second, the possibility of getting reductions of the target protein up to 90 or 95%. And the third advantage is that the duration of the effect goes for months, which means that we can improve remarkably the compliance of our patients. So you can see that another advantage of this new technology is that we can target molecules with which we failed in the past using the traditional approaches. And of course, the ultimate goal is to modify DNA. And already we have studies showing that DNA-based technology can modify the synthesis of proteins, which are dangerous for our body. And in this case, one shot, one injection is sufficient for life. Of course, this is a more risky game because DNA, once changed, is forever. So we must be very careful. There are important ethical issues related to this technology targeting DNA. But now, at least in theory, and also to some extent in practice, we have drugs which can modify DNA and for which one injection in life is enough to cure the disease. Well, this is the usual story with all technologies. New technology must be governed in the proper way because each new technology can be extremely useful or can be extremely dangerous. Uh, Even cars, I mean, cars are extremely useful. We use them every day, but a car can kill a pedestrian. We have hundreds of thousands of people who die because of car accidents. So any new technology is by definition risky. And the risk here, of course, is present, but also the potential advantage is huge. Is huge because we can simplify the life of doctors using artificial intelligence in order to improve risk stratification or in order to improve the diagnosis. So these are tools which, if well utilized, they can be extremely useful for the doctor, but the final decision, the final clinical decisions must be based on the integration of the information we have. So if the time spared by artificial intelligence is utilized to improve our relation with patients, well, this is really very welcome because frequently doctors do not spend enough time with their patients explaining what we do and how we treat disease. This human relation between patient and doctor is fundamental for a good diagnosis and for the implementation of a good treatment. Artificial intelligence very simply can simplify our life, allow to reach conclusions more quickly than before. If the time gained by these quick solutions provided by artificial intelligence is utilized in an intelligent way by the doctors, again, perhaps spending more time with patients, well, if this is if artificial intelligence is utilized in this way, I think that it can be extremely useful. At the other extreme, if we uh, use artificial intelligence to make the final diagnosis without any critical interpretation of the data provided by artificial intelligence, well, then this can be extremely risky. If I trust the machine, which tells me that this is a severe aortic stenosis, but I do not verify. And if I do not put this information in the context of all the other clinical informations, well, this can be very much misleading. So if the artificial intelligence, in few words, if the artificial intelligence is governed by doctors, can be extremely useful. If doctors are governed by artificial intelligence, this is extremely dangerous. Yes, I spent 15 wonderful years, mainly in the UK, in London, at the Hammersmith Hospital, and some time also in the US. And this experience has been extremely, extremely useful. Then I went back to Italy because it is always more challenging to implement your expertise in your country. It's challenging, but very attractive. So I'm very happy of my going back to Italy. My experience in UK and US was wonderful. I learned a lot, but was also stimulating to transport back to Italy the experience acquired in UK and US. I think that this is for everybody. I think is important. Would be useful to have a working experience abroad because you receive new stimuli. There are different approaches to work, and if you combine the experience in your own country with the experience gained in other countries, well, you, in a sense, become a richer person, richer in experience. And this is can be extremely productive. Now, this doesn't mean that the attitude uh, to work on the results of our activities are different in US, UK, or Italy. At the end of the day, the results are very similar, and but the approaches are a bit different. And I think that to learn to gain experience in different countries enriches you in pursuing your goals. So on average, again, the approaches and the results are similar in this in Europe as in US. The ways are slightly different. If you're exposed to these different approaches, at the end of the day, is enriching, enlightening, and more fruitful. My suggestion is to really, for all younger colleagues, to work, to uh, to consider having experiences abroad because this is enriching. Again, no major differences among these countries, but a more comprehensive approach, which can only be based by exposure to different systems. At the end of the day, is pleasant, is interesting, and is rewarding. Well, it's of course we're under pressure, but I think I'm sure there are ways to find enough time to discuss with our patients. And I think that the most important quality in a doctor is curiosity. If curiosity is there, then our work becomes much more attractive and much more fruitful. The uh, the Also, when I speak to my students or to my trainees, the example I propose is the book of Agatha Christie. A patient is like a book of Agatha Christie. And typically, in the first half of the book, you find clues to the assassin, to the bad guy. The first half of the book is plenty of clues to what can be the solution of the enigma. And then in the second half of the book, you find how these clues lead to the culprit, lead to the assassin, to the guy responsible for the murder. And our relation with patients is like a book of Agatha Christie, because we need clues, and these clues only come initially from the patient. It is important to ask the right questions and to interpret properly the answers we receive. It is important to visit, because there's no shortcut. No shortcut. No shortcut. To visit is important also because visiting and putting together the clinical history allows the doctor to propose a working diagnosis. And then, of course, tests are important to prove or disprove this working hypothesis. But it happens that if our working hypothesis is confirmed by test, then we can be pretty sure that the diagnosis is correct. But it happens not infrequently that our working diagnosis, our working hypothesis is not confirmed by test. And then there are two options. Either the tests are wrong or the working hypothesis is wrong. And both things can happen. So I think that if we are curious, if we ask questions to the patient, and this takes time, but also allows to create this really good relation between doctor and physician, which is fundamental for a good treatment. So if we have enough time, we create this pleasant atmosphere with the patient, and this is fundamental in order to get all the information we want to have from the patient. Well, then I think that this is a solid starting point. Then artificial intelligence can help us. Diagnostic tests are fundamental. But once we have this we establish this strong emotional, empathic relation with the patient, and once we have all the important information only the patient can give us, then we are really on solid grounds. And then all the rest follow in a sort of logical way. This is why it happens to say from time to time, again, speaking to my students and trainees, to be a doctor is the best work of the world, for two reasons. Because you have the opportunity of establishing these wonderful human relations we have with our patient, but also because it is an intellectual exercise, because takes time, dedication, and intelligence to interpret correctly the clues given by the patient in order to put the assassin in jail.